Now we see.
Yeah, sorry for the delay. Good afternoon, everyone. At the outset, I would like to thank the organizers of World Congress of Urology and Nephrology for this opportunity. My tryst with continence surgery in women. Being a female urologist, most of my work has been dealing with women who suffer from urinary incontinence, which is defined as involuntary loss of urine by International Continence Society. And urinary incontinence is the most common urological problem, affecting almost 40% of the women over the age of 50 years. Among the different types of urinary incontinence in women, stress urinary incontinence is the most common type, either as pure stress incontinence or as mixed urinary incontinence along with urgency incontinence. It can have a serious impact on the quality of life of these women, as it affects every sphere of a woman's life, right from social, occupational, domestic, recreational, marital, and believe me, even spiritual life. Many of these women with severe stress incontinence, when they kneel down to offer prayers, they leak urine, and in many religions, it's not acceptable to pray when the clothes are soiled in urine. Thus, a seemingly trivial problem like urinary incontinence can devastate a woman's life. When the woman does not respond to pelvic floor muscle training, the only option left is surgical correction of stress urinary incontinence. And we have basically two types of procedures to correct stress urinary incontinence. Either bladder neck suspension by vaginal Kelly's plication, or needle suspension of the bladder neck by STEMIs or GITIs, or sometimes it could be retropubic bladder neck suspension like Birch Kalpa suspension. Here, the aim is to reposition the bladder neck above the level of pelvic floor in women with urethral hypermobility. But for women with intrinsic sphincter deficiency, we need to put a sling under the urethra to buttress the urethra and increase the urethral closure pressure. My tryst with continence surgery in women has started during my urology residency in mid-90s. Among the myriad surgeries available in those days, modified STEMIs was the most favorite among urologists of a busy public hospital because it could be done quickly as an outpatient procedure, and most of the times it could be completed under local anesthesia and the patient can go home on the same day. But I soon realized when I became a consultant and started my own female urology practice, I realized that though the short-term results with STEMIs were good, most of these women would come back with recurrence within 6 months to 1 year after the surgery. So I started offering my patients Birch Kalpa suspension, which has been the gold standard in those days, and it has been the gold standard till the turn of this century. Here, we suspend the periurethral fascia to a strong support like Cooper's ligament by means of non-absorbable sutures to elevate the bladder neck and reposition it in its normal anatomical position above the level of pelvic floor. And Birch Kalpa suspension has another advantage that it could be clubbed with other concomitant abdominal surgeries like hysterectomy or sacrocolpopexy. But this is effective only for women with urethral hypermobility and not so good for women who suffer from intrinsic sphincter deficiency type of stress urinary incontinence. These women would need a sling either made of autologous fascia or a synthetic sling. We need to buttress the urethra, and this sling in a conventional pubovaginal sling procedure, Aldridge's pubovaginal sling, it's placed under the bladder neck. Since we need to fashion a sling either from the rectus fascia or from the fascia lata, most of my patients would opt for a abdominal, that is from the rectus facial sling, because they don't want an incision on their thigh. Many of these women would have already had a abdominal surgery earlier, either a cesarean or hysterectomy, so they don't mind having having an incision on their lower abdomen rather than having on a thigh. So here the rectus facial sling is fashioned from the anterior rectus sheath, and here the sling is placed under the bladder neck through a vaginal incision, and the suspension sutures would go through the retropubic space and will be brought out through the abdominal incision, and we have to tie the suspension sutures on the anterior rectus sheath. But how much is the right amount of tension with which we need to place the sling? We need a cystoscopic guidance to see how much is the bladder neck elevated and how is it closing from the incompetent bladder neck. Here you can see how under cystoscopic guidance we determine, but the optimal tension, how much is it, we can only learn from it with experience. But another advantage of doing a cystoscopy is to rule out any bladder neck injuries. Though this procedure has given excellent results in terms of continence, in spite of high morbidity because of two incisions, one in the abdomen, one in the vagina, but almost 25 to 30% of these women would require a CIC for long term, either lifelong CIC or an indwelling catheter, because they have severe post-operative voiding dysfunction. But let me tell you, here in the Indian scenario, if a woman requires catheter after continence surgery, in spite of having good continence, the surgery is doomed a failure. So in this scenario of uh, various surgical options where the minimally invasive procedures are not effective, and a good procedure which is associated with high morbidity can result in serious voiding dysfunctions requiring a catheter, the surgeon is really confused as to what he or she has to offer their patients. So in that scenario, we have the mid-urethral slings, which have revolutionized the surgical approach to female stress urinary incontinence and have become the new gold standard, replacing birch as the new gold standard, because they're minimally invasive, have low morbidity and very high efficacy, and they're useful, effective for both types of stress urinary incontinence, both urethral hypermobility as well as intrinsic sphincter deficiency. That's the prototype mid-urethral sling, the gynec activity. You can see the size of needles is a bit scary for the surgeon who is a novice. Here the needles are attached to a ribbon-shaped mesh, which is type 1 proline mesh, which means it is macroporous and monofilament. This allows the fibroblasts and macrophages to go through the pores, and this helps in the mesh getting incorporated into the host connective tissue. I performed my first mid-urethral sling in the year 2003, though it has been introduced into the Indian market a year earlier. But I was skeptical in offering this to my patients, one, because of the cost, and second, I wasn't really sure about the long-term results. But I was fortunate enough to have been trained hands-on by a pioneer in this field, an Australian urogynecologist, who motivated me to go ahead. And my first patient was my relative whose spouse was a physician, so they could give me an informed consent, and I went ahead and did this procedure in 2003. For the last 18 years, this lady, who was a very active socially active entrepreneur, couldn't go on any of her business trips because of severe stress incontinence, but after her mid-urethral sling in 2003, she is still continent and very happy about the surgery. But apart from the technical complications related to the blind passage of the needle, since that big needle has to go through the retropubic space almost blindly, there is a risk of both bladder injury, bowel injury, and very rarely major vascular injury has been reported in the literature if one is not careful and one doesn't adhere to the standard uh, surgical anatomy. And apart from the technical complications, there can be some functional complications like voiding dysfunction and detrusor instability, though they are much less common as compared to the pubovaginal sling. So to eliminate the blind passage of the needle through the retropubic space, the transobturator mid-urethral slings have been introduced, because we don't have to go through the retropubic space and injure the bladder or blood vessels. Here, the mesh goes through the obturator foramen either from inside out or from outside in. If you look at this picture, we can see very clearly up to the turn of this century, all the surgical procedures for stress urinary incontinence were named after the pioneers who invented those techniques like Kelly, MMK, Birch, Stamis. But from year 2000 onwards, from the early 2000, where most of these midurethral slings which have been invented by these pioneers, we hardly know their names: Olmsted, Petros, Delorme, because here now we know the names given by the industry. And in the present day industry driven world, where we have different types of midurethral slings like retropubic sling, where the needle goes from top to bottom or from below upwards, or transoperator sling from outside in or inside out, the young surgeon has to be really careful as to what he or she can offer to their patients, because we have to decide based on the literature, what the data shows about the efficacy of different types of slings, what are the side effects, what are the complication rate with each type of sling, and more important is in which procedure he or she is trained and confident of performing. And finally, it's based on the individual needs of the patient. For example, if the patient is an athlete, we would avoid a transoperator sling because we don't want any groin pain, which can be a possible side effect with transoperator sling. And similarly, if a patient had previous abdominal surgery, try to avoid a retropubic sling because there's a higher incidence of bowel injury with retropubic sling. So here the literature says that the transoperator sling has a lower risk of bladder injury, bowel injury, vascular injury, and even voiding dysfunction. And one more study by Castlo et al. Has uh, uh, mentions that there is increased risk of bowel injury with retropubic midurethral sling in women who have had a previous abdominal surgery because of the possible adhesions. So we need to be careful in what we choose for the given patient. And if you look at this table comparing the complications with the retropubic sling, that is TVT, with the transoperator sling, not only the technical complications related to the needle passage like bladder injury are more with retropubic sling, but even the functional complications like voiding dysfunction, de novo urgency are all high with retropubic sling as compared to the transoperator sling. This is probably because the retropubic sling is acutely angled under the urethra and may have some compression effect on the mid-urethra as compared to the transoperator sling, where it passes through the obturator foramen and has a more gentler curve under the urethra. So I started doing transoperator sling for the obvious advantage that there is no risk of injuring the abdominal viscera, and then initially started with outside in and then moved on to inside out transoperator sling. So far I have completed 500 midurethral slings till date. In the initial days of retropubic midurethral slings, there were some incidents of bladder injury, but fortunately all of these were detected intraoperatively because cystoscopy is mandatory in these patients, and there are no serious consequences if we recognize the injury and remove the needle and reposition the needle lateral to the bladder wall. But one patient where I performed an inside out transoperator tape had obturator neuropraxia, that is, in the post-operative period she couldn't adduct her leg, but fortunately it resolved within 2 days. Here again I didn't exit more laterally to go and hit the operator nerve, and my landmark was fixed like in all other patients, but probably it is a foreign body reaction generated by the the synthetic mesh, and which has probably irritated the operator nerve. And fortunately for the patient and for me, the patient recovered within 2 days. Comparing the results with outside in and inside out transoperator tape, the meta-analysis shows the efficacy and as well as the side effects like groin pain and voiding difficulty are comparable between two different types of obturator sling, but there's a higher rate of vaginal angle and lower tract injuries with outside in transoperator tape because the needle may hit the urethral wall, as well as we may go through the lateral fornix, and if we don't identify the injury intraoperatively, there can be mesh erosion at a later date. So that is my most favorite midurethral sling, the inside out transoperator sling. You can see the same ribbon shaped mesh as in the prototype TVT, but here the needle shape is different because it has to negotiate a different curve, that is the obturator foramen. I just want you to observe these two pictures. Why I prefer inside out transoperator tape as compared to outside in. Here, not just the length of the incision and the vagina, because this relates to the amount of dissection we do in the paraurethral area for the needle to pass through the paraurethral tunnel. As long as we keep the dissection to as minimum as possible, the periurethral fascia is not damaged, and this I believe is crucial. We need to preserve the periurethral fascia because this helps in the mesh getting incorporated into the host tissue, whereas in the outside in transoperator tape we need to create a wider periurethral tunnel because we have to take our finger up to the pubic ramus to bring the needle from outside into the vaginal incision under our finger guidance. So if we leave too much of space here, the sling can get dislodged in the early post-operative period. Here, the midurethral sling, the principle is we don't fix it with sutures. It has to get incorporated into the host tissues within, which happens within a time of 1 week to 10 days. So if we leave too much of free space here, the mesh can get dislodged, and that will significantly reduce the success rate of the surgery because most of the failed midurethral slings, the post-operative ultrasound has shown that the tape is not under the midurethra where we were placed it originally, but it has got displaced either proximally or distally. So for that reason, I always prefer inside out transoperator tape. Here you can see only sharp dissection, and it's a very minimal, very short or very narrow parallel tunnel, just enough for the needle and the wing guide to fit snugly. There is no free space around the needle. So once we remove the needle and place the mesh is sitting snugly under the midurethra. There is no place for it to migrate, and this will increase our success rates. So coming to the TVT abbrevo, where it's similar to the inside out transoperator tape, but the mesh is short. Here, the aim is to minimize the length of the mesh to which the host is exposed. Through the groin, only the suspension sutures exit, and once we cut these sutures, the mesh is short and it's not in the vicinity of the obturator nerve, so the incidence of groin pain may be less. This is another single incision mini sling where we only give a vaginal incision, there is no exit wound. This will minimize the complications, the intraoperative injuries, because there is no blind passage of the needle either through the retropubic space or through the transoperator foramen. Here the mesh ends in the obturator internus muscle. This, though the complications are less, the efficacy is not as high as in the standard midurethral sling. I've used this in a couple of patients who were high risk for surgery because we can complete this procedure under local anesthesia, and those who were diabetic or those who were anticoagulants because the risk of vascular injury is minimal with this procedure. So, what are the tips I would like to give to the young urologists? Because the midurethral slings are excellent procedures, but we are worried about certain technical complications related to the blind passage of the needle. So, to minimize these technical complications, one should know the surgical anatomy well and always adhere to the recommended anatomical landmarks, because any slight deviation in needle trajectory can result in major disaster. In retropubic sling, even if there is 5-degree lateral movement of the needle from the recommended needle trajectory, it can hit the iliacs, and the results can be disastrous. And we are worried about the long-term dreaded complication, that is erosion caused by the synthetic mesh. And again, to minimize this erosion, we need to use good quality mesh, that is type 1 mesh, which allows the fibroblast to grow through the mesh, and this allows new uh, collagen tissue to form, and this helps in the mesh getting incorporated into the host connective tissue. After a couple of months, if we go back for some reason, if the patient is in retention and if we want to remove the mesh, then we can hardly find the mesh in the surgical site because it is incorporated into the host tissue, so it doesn't act as a foreign body anymore. So that is the type of mesh we would like to use, because we don't want a foreign body forever there, which can cause a lot of other complications like erosion. Preoperative estrogen is recommended for women who have atrophic vagina, because This estrogen can regenerate the vaginal mucosa and minimize the risk of vaginal extrusion in the elderly patients. But the most important factor which determines the rate of erosion and where we can be careful is adopting proper surgical technique. As I said, do not dissect too much of periurethral fascia, because this is crucial in helping the mesh to get incorporated into the host. And optimal tensioning. If we use too much of tension under the mid urethra, there can be urethral ischemia and erosion. So the tension should be optimal. Again, we will learn this only through experience. Intraoperative cystoscopy is mandatory to rule out any bladder perforation with the needle. Inspect the fornices, especially for transoperator sling. If we miss a fornicial injury, the patient can later present as a case of vaginal extrusion of the mesh. And in conclusion, how do we decide? There are so many surgical procedures which I just described, and there are many more which I haven't discussed. So, how can a surgeon decide what to offer to a patient? According to American Urology Association guidelines, the first line treatment for stress urinary incontinence should always be conservative with pelvic floor muscle training, with or without biofeedback. But for those women who don't get well or who don't get enough relief with pelvic floor muscle training, and only option left is surgical correction. And there is grade A recommendation that we can offer the patient any of the procedures like midurethral sling, pubovaginal sling, birch, or bulking agents. But here, only after we counsel the patient properly and after discussing the pros and cons of the all the surgical procedures, we should allow the patient to make an informed decision. And what do we have on the horizon? Energy-based devices like fractional CO2 laser is very effective for women with mild stress urinary incontinence because it stimulates new collagen synthesis. And this, when clubbed with PRP, the autologous platelet-rich plasma prepared from the patient's own blood, this acts as a synergistic uh, tool to increase new collagen synthesis. And when the energy based devices like CO2 laser is clubbed with pelvic floor muscle training, because we are targeting two components of the pelvic floor, one the muscular component, one the connective tissue supports of the bladder neck, the patient will have good relief if she has mild stress urinary incontinence. So the energy based devices are a boon for those women who have mild stress incontinence and who doesn't respond to pelvic floor muscle training, but who are not candidates for surgical correction. For mild stress incontinence, we don't want to take the patient under the knife, and sometimes there is a contraindication for surgical corrections. So for all those women, fractional CO2 laser or any other energy-based devices would give good results. Thank you for your patient hearing.
Thank you, Dr. Lalitha. So interesting presentation. Colleagues, have you got any questions? No questions. Thank you, Lalitha.
I will stop sharing. Yeah, thank you so much for the opportunity once again.
The next speaker is Carolina S. Dengros, proton pump inhibition use and risk of chronic kidney disease and stage renal disease, systematic